Welcome to AUA Leadership in Business, an official podcast of the American Urological Association.
Welcome to the AUA Leadership in Business podcast, where urologic professionals experience the practical application of business acumen essential for success in today's dynamic professional landscape. I am Dr. Micheal Darson, and in today's episode, we will discuss monetizing and incentivizing artificial intelligence and telemedicine in urology. Joining me today for this discussion is Dr. Giovanni Cacciamani, urologist and surgeon scientist. He is Associate Professor of Urology and Radiology at the University of Southern California, Director of the Artificial Intelligence Center for Surgical and Clinical Application in Urology, and Vice Chair of the Research Council at the Department of Urology of USC. He works on oncological diseases, patient safety, and AI applications in healthcare. Dr. Cacciamani is the chair for the Young Academic Urologist Urotechnology and Digital Healthcare Group of the European Association of Urology. Dr. Cacciamani was awarded Citizen of the Year in Verona, Italy in 2022 for healthcare innovation and the Italian Matula Award for Best Urologist Under 40. His lab currently is exploring the potentialities of generative artificial intelligence in healthcare for making AI practical for the practicing physicians. He's authored about 300 publications and has given approximately 150 lectures in new technologies, artificial intelligence, and digital medicine applications in urology. Dr. Cacciamani, welcome.
Thank you so much, Dr. Darson, for having me here.
Okay. Well, let's get started. Let's talk about, why technology is important in urology.
Well, I would say that is a very fair and simple question. So at the end of the day, urology has always been in pole position to testing new technologies. From the early days of the first endoscopes to the lasers, to the robotics, and of course, telemedicine and artificial intelligence are not an exception. And they found a fertile ground in urology.
So let's talk about how artificial intelligence is entering the arena.
So artificial intelligence has to be considered as a discipline under which we have machine learning, deep learning, generative AI lately. And again, the potential application of artificial intelligence in urology are literally countless. Imagine that, for example, when we are talking about the potential application, we have to consider that those applications are spacing from the imaging recognition, for example. This is something that we have to consider, especially when we are looking, for example, the radiological imaging or pathological imaging. It can be used, for example, for diagnosis, improving the accuracy of the diagnosis, improving the patient workflow optimization, and why not the automated data extraction. Imagine how much time and how many errors actually we can have when we are extracting the data. And that's the main reason why the majority of our studies, unfortunately, in medicine are done retrospectively. How cool would be of having this white collar assistant that is extracting the information in real time. Other potential applications are, for example, surgical training and artificial intelligence assisted surgery, where, according to the latest data, we'll have the major increase in revenues when robotic surgery and AI are implemented together, with a projected value of more than 40 billions in 2026. It can be used, for example, for big data analysis, for precision medicine, and predictive modeling, for example. Imagine that right now we are using a lot of nomograms, but those nomograms are based in the majority of the cases on statistics. The use of artificial intelligence is different because you can go backwards to understanding, not from the predictors to the predicted, but the opposite. And again, as I was saying, urology is moving towards this, to test this kind of technology. Imagine that just in 2014, the number, I was looking at this number this morning, the number of abstracts on artificial intelligence were only 2. Last year, so this year in 2024, the number of abstracts presented at the latest AUA reporting the name, at least in the title, for large language models or generative AI or artificial intelligence machine learning was almost 500. So this actually is showing you that how much our specialty is interested in testing new technology, especially artificial intelligence. And on top of this, we have to consider that our flag journal, the Journal of Urology, now has a specific section. The name is Technology, Digital Health, and Artificial Intelligence, that I have the privilege of assisting Dr. Gill, who is the section editor for that, and I am assisting him as associate section editor for this specific section that will have the mandate of improving the literacy amongst our peers for artificial intelligence.
Yeah, talk about rapid evolution. That's an example of it. 2 abstracts to 500. Does artificial intelligence have a role in surgical simulation?
Oh, well, absolutely. I mean, imagine that. We have to make a distinction. The possibilities and the actual capabilities of this technology. Possibilities, as I was mentioning, are countless. Imagine we can train train artificial intelligence models in understanding how a proper radical prostatectomy could potentially be done. And then once it's trained, the system can advise the surgeon or the surgeon in training in performing that particular step before or after another particular step. Imagine that, for example, now the latest advancement for generative AI, Google Research and Google DeepMinds, they just released a publication a couple of days ago. They were evaluating the capabilities of MedPalm. The name is now MedGemini. Which now has the possibilities of making image recognition in real time on videos, finding out, for example, the anatomical structures. And imagine how this could potentially impact on our daily practice in the future when those systems are implemented, for example, in robotic surgery and training. This could potentially find out immediately possible anatomical variants that we know sometimes are related to adverse events with the potential catastrophic effect during the surgery. And this is just an example. The other potential example on training is the unbiased evaluation. I mean, how many of us, before going to a restaurant, will look at the reviews on Yelp or on Google? And this is something that all of us are doing. And when the stars are a little bit less than 4, we're going to start saying, maybe we should go to another place. Or at least in my case, I'm going to check immediately the better reviews to understand what I could potentially expect. And if that particular review is related more to the evaluator than the actual gaps or lacks of the particular restaurant. For the same reason, surgery, medicine, unfortunately, we are evaluated like restaurants. And this is a biased evaluation, because we don't know who is evaluating us and with which kind of metrics. Artificial intelligence can be the perfect ally for evaluating our performance as surgeons, as physicians, as general urologists, in a way that it can be unbiased. It can be the evaluation can be done with specific metrics, and therefore this kind of evaluation, once it is done, can also make us thinking. Maybe I should, for example, do a different procedure than another one, or I should focus more on this kind of patient, because in this kind of patient I need to provide better expertise, or I should focus more on this part of the decision-making process than the other. So again, AI can be the perfect, I was saying, a white-collar assistant that can really help us in improving our performance, decreasing our workload, keeping the workflow. As my chair, Dr. Gillis, used to say, AI is the perfect ally and the perfect venue for bringing back the joy of practicing medicine.
Great point. So are you saying that, so AI and the surgical simulation, you're able to evaluate particular steps of the operation for a resident in training? Like,
you can do that. So once the system is able to segment in the video and the metrics are going to be implemented in the evaluation, each segment can be evaluated on performance. Right now, the way that we have for evaluating the performance are, for example, the gear scale evaluation, which again is based on a subjective evaluation. If you have a system that automatically, let's say that we're going to have the best robotic surgeons that are going to give us all the robotic surgery for radical prostatectomy done, and they're going to select only those cases where the system was able to provide the better outcomes. We can train the model to understand, to make it understanding how the radical prostatectomy should be done. And therefore, once a newborn in surgery, surgeon in training is performing the radical prostatectomy, well, the system, if properly trained, can tell you, hey, you should do this because when you're doing this kind of step or this kind of maneuver, technically you have better outcomes.
That's fascinating. Are we at the point that we can go through a surgical simulation and introduce a complication to a resident in training and see how they perform? Like a bulldog comes off a vascular, a vessel or something like that. Are we at that point?
Okay, so for now, right now, no. Because of course there are a few things that we have to consider, especially for intraoperative adverse events. We are part of an initiative. We are leading this initiative. The name is ICARUS. ICARUS stands for Intraoperative Complication Assessment and Reporting with Universal Standards. And we started this initiative 2 years ago because we figured out that there is no a clear definition of intraoperative adverse events and their possible effect. For example, a lot of people are talking about transfusion as a complication, when transfusion technically is a treatment that is related to an effect related to an event. So definitions are important. And before going into simulating potential scenarios and evaluating the performance of the surgeon in dealing with that scenario, the very first thing that we have to do is making the proper definition of those events and therefore classifying them. Once they are classified, then we can actually move towards the digital, I would say, more than augmented reality, virtual reality setting, where we can simulate the adverse event, the intraoperative adverse events, and therefore evaluating the performance of the surgeon training in dealing with that. One of the things that, for example, we have to consider is that imagine how many of us are scared of having an intraoperative bleeding and not finding the source of the bleeding. So because sometimes we know those vessels are going out, are retracting, and if you're not acting immediately, chances are that you're going to not find the target where you can clamp. So technical artificial intelligence, while it is recording the video, can and once it identifies that there is a bleeding, the system can actually point in the camera and give you the target where was the vessel, and therefore helping the surgeon in clamping it. That is one of the possible application of surgical, I would say, surgical assistance. Let's put it this way.
How about by the way, this is a fascinating topic. So how about the ability to tie preoperative imaging to the operation? Say that there's a lumbar vessel that's really engorged and you don't see it, or perhaps AI could help, like you said, change the steps so you can minimize the risk, so to speak.
Well, that is another excellent point. So, for example, the evaluation of anatomical variation is extremely important. One of the things that we are trying to do here at the USC, we are, as part of the ICARUS Global Surgical Collaboration, we are trying to create a dictionary of all the possible anatomical variation by surgical procedure. That we feel is extremely important to inform whomever, like expert surgeons to the medical student, to understand that the variation is always around the corner and the chances of having a catastrophic effect is also there. Your question was how I can basically merge the preoperative imaging into the surgical field in a way that actually I can inform the surgeon that there is a variant and therefore recognizing the variant. So right now, the main limitation of this technology, which is extremely fascinating, is that it requires a back-end work before the surgery of linking the imaging and with the actual visualization of the surgical field. And this, of course, requires time and requires person dedicated, and it is expensive. The real game changer, and this is something that some centers, for example, the Orsi Academy with Alexander Motri and Peter De Bacele, or with Dr. Porpilia in Turin, they are actually doing this superimposition of augmented reality into the surgical field, AI based in real time, without any kind of preparation in the back end. This will reduce, of course, the workload. It will make everything easier and faster. And probably that will be the first step for having this kind of augmented surgery, like surgery 2.0, where is no more virtual, but is augmented, which is a totally different thing.
I'm going to say this word a lot, I think, during this podcast, but this is fascinating. Talk to us a little bit about technology and telemedicine.
Okay, so there are a few things that we have to consider. Telemedicine has emerged as the possible application, I would say the most technological and low-hanging fruit of technology after the pandemic. Before the pandemic, nobody was using telemedicine. And if you were proposing to a patient, hey, I'm gonna visit you online, they will start saying, no, I prefer to come there. And with all the the drawbacks of this, I mean, you have to take out one day of your life, having probably somebody is coming with you, driving, for example. We know that telemedicine has an impact also on the green, on there's an impact. The carbon footprint of telemedicine is important, and not only that. I mean, people were actually not that confident, even physicians. But then we have the pandemic, and I would say that this is the only one gift the pandemic gave us as physician. So telemedicine became a need. We need to visit our patient. We need to keep going with the with the evaluation of our patients, with the clinical evaluation, etc. And telemedicine was the only way to do that. And if you're looking at the latest data, well, besides the fact that of the market value of telemedicine, which is huge, there are like more than 50 companies that are providing telemedicine. But again, this is something now accepted. Before pandemic, if you were asking to a patient of 75, 80 years old, hey, do you have to use the laptop or you have to use an iPad? They were saying, no, I'm not going to do that. Now, iPads, these kind of devices are, I would say that pandemic made, I would say, a digitalization of the elderly population. That, of course, it was a need, a necessity, but now we can take advantage of that.
Yeah, before I moved to New Orleans to go to work at LSU, I worked in Arizona in Scottsdale, and we would have people that would drive 2 or even 3 hours one way for an appointment from Northern Arizona, and telemedicine or telehealth changed their lives for the better. There's all day trips to the doctor. So, and you're right. I think with the advancements in technology, people that aren't necessarily tech savvy are probably more tech savvy than they think, and getting on a telemedicine call or a telehealth visit is a lot easier for folks now. So let's talk about what is the status of AI in urology currently.
Okay, so there are a lot of potential applications, as I was mentioning, from imaging recognition to surgical training to optimization of the clinical workflow. So we have to consider one thing. Urology is a beautiful specialty. Is extremely variegated, heterogeneous. We space from use of lasers, use of robotics, open surgery, challenging cases, but also clinics. And also we have endoscopy. So it's, I would say, the most complete specialty in the world. And this is beautiful. But we know that the majority of us is in burnout. 68% of urologists are in burnout. 72% of residents are in burnout. They are stressed out even before starting. And this actually is something that we have to consider. Our population is aging. The urological disease is increasing, and the actual urological work manpower is reducing. And this actually could potentially have a catastrophic effect on the healthcare system first, and on the service and the performance that we can provide to our patients. And again, we are humans, we are not superiors. And here is the potentiality of artificial intelligence. Again, bringing back the joy of practicing medicine. Or, in other words, as Eric Topol used to say, making medicine human again. How many of us, how many times you find yourself in writing on a computer for 15 minutes while you are having a clinical consultation, and you are not actually paying attention to our patients? I mean, let me give you an example. I find myself in a very challenging situation a couple of years ago when my fiancée, she was diagnosed with myeloid leukemia, acute myeloid leukemia. And I figured it out that and I have to assist her, I have to take care of her. And I was going with her to the oncohematologist. So I find out myself, first, not understanding what the colleague was telling me. And I'm a physician. So imagine how much, I would say, how much difficult it would be for somebody who is not even a doctor. And especially in these cases where where a patient needs the most the human touch, we are spending time in typing to a computer. And this is because it's a necessity. We need to write down the information. And sometimes, the patient is going to be asked the same exact thing 3 or 4 times from the PA, from us, from the nurses. And then people are going to say, hey, are those people communicating each other? So why they're always asking me the same questions? Well, technical AI can be the perfect ally for doing that. There are some new advancements that would potentially help us in reducing the typing to the computer. How much time, for example, as physicians, we are spending as work outside work? It has been reported 8 hours per week. Why I'm using this time, not spending this time with my family or for myself, going, for example, to the gym or having a nice walk, and actually I have to prepare myself to clinic, when this stuff can be done automatically by AI assistants. And there are some AI models, such as, for example, One Line Health is one of the ones that we really want to test soon, where we are actually are able to make the patient providing those information before the clinical consultation. And as surgeons, we are receiving a report that is perfectly structured and actually is reducing our workload. Again, the other potential thing that we have to consider is this one. Dr. Google is always around the corner. Sometimes it is the first consultation. We are the second one. When a person has blood in the urine, they go straight on Google to get an information. The main problem is when the patient is going to Google to gather information after the clinical consultation. And that, in my opinion, is our failure. Main reason is because we don't provide enough information to the patients, or we don't seems to be too open to much questions. And we really need to flip that percent of, let's say, a slot of 20 minutes, of 15 minutes in typing to the computer and 5 minutes dedicated to the patient, to 15 minutes with the patient and 5 minutes to the computer, or probably less time, let's say 10 minutes instead of 15, we can see more patients. Or why not going home a little bit earlier and stay with our family?
How close are we to, a private practice community urologist, utilizing AI and benefiting from it?
Well, that is an excellent question. So I would say that regulation inside academic institution and regulation for private practice is a little bit different, right? And potentially private practice will benefit the most and faster than the academic centers. Again, regulation are important. And those regulations are extremely important now that we are using this new technology, also because we know that this technology can impact on the patients. But on the other side, we cannot make those regulations making this technology old. The FDA, for example, is doing an excellent job in reviewing faster and faster and faster with new checklists these kind of technologies. I was looking just a couple of days ago on the number of FDA-approved softwares that are using AI. Now there are more than 800. And just in 1 year, were approved 400. which means that even if in 2 years you got half of the approval, it means that even the FDA is making the excellent job of recognizing the value of, say, hey, calm, let's wait, let's check it out, let's evaluate the performance. But the way that the performance is evaluated now is faster, and this is actually is going to benefit this kind of technology, because of course we cannot wait like 4 years when this technology is going to become not old, it's going to become like basically archaeologic. Let's put it this way.
How is the FDA involved in the regulation of AI in healthcare?
Well, that is fortunately the FDA is involved because there are new regulation, there are new pathway for evaluating those softwares. I was looking at literally a couple of days ago on if you look at the artificial intelligence machine learning enabled medical devices, right now at May 13, there are 191 artificial intelligence machine learning enabled medical devices that are added, and the FDA has authorized 882 AI machine learning medical devices. Again, this is making the point that this kind of technology is exciting. We have to be enthusiastic of the technology, but again, we need to make the FDA making their own evaluation. Because let me give an example. Let's say that you have a brilliant way for reading automatically the multiparametric MRI. And this is showing you that during the training setting, you have an accuracy of 86%, 90%. And then you do an internal validation, and it's dropping a little bit of, let's say, 87%. Well, all good. That is the perfect starting point. But then those performances to be evaluated in the real world with databases that can be shared amongst institutions where they are testing different machine learning or AI models within the same population. That's the main thing. Again, there is a lot of enthusiasm, which actually is something that is good. Urology research and urology, the urologists in general, really want to test and evaluate this technology. But I'm very, very glad that the FDA is overseeing like an umbrella everything. Also because, again, we are not, we are working with our patients. And we really want that this technology will provide a benefit more than harm.
Very interesting. And you've kind of touched on this, but I want to go into it a little bit further. Talk about artificial intelligence and economic efficiencies.
Okay. So again, this is based on the fact that artificial intelligence can reduce the workload, keeping the workflow and improving the performance. You can reduce, for example, the medical errors. You can improve the way that you can optimize the way that we do clinics, for example, as I was mentioning before. Let's say that you have 20 minutes to stay with your patient. Well, technically, you can optimize that in a way that you can reduce the work outside work. And the system can extract information from the patient at the very beginning, before the medical consultation, and then you're going to receive a checklist with all the important information about the past medical history, surgical history, medication, and whatever, and you don't have to ask them again. And this, of course, is impacting, because if you can see, let's say that you can see 20% more of patient, well, that is a huge number. Is one, I would say, 4 patients more if you have 20 patients per day in clinic. And this, of course, impact on the economics of an hospital. And this is just the beginning. For example, the automated extraction of the CPT codes. Sometimes we have like a list of CPT codes that we apply, but each patient is different. Even a question that is different technically could potentially lead to to the requirement or to order a new exam, and that exam has to have added to the billing. Again, if we can have a system that automatically is going through that, reading everything and extracting all the CPT codes, updated CPT codes, well, that is a game changer.
Yeah, these numbers that we're talking are very significant. It's increasing efficiency by 20%. I mean, that's a real number for sure. You talked about the EMR. Let's go a little bit further with the imaging. Can you talk about AI and how it's impacting interpretation of imaging our use of it?
Absolutely. So imagine to have let's focus on the multiparametric MRI for prostate cancer. Each multiparametric MRI is made by pixel, and each pixel, dependently if is a pixel for a lesion or for a nodule, for example, in the prostate, or for a normal part of the prostate, has a corresponding pathological images, right? So the real value of AI is merging each pixel into the radiology with each pixel in the pathological imaging. That merging will give you what we call the pixel radio to pathological characteristics. So now when you have a lot of cases, you can identify a group of variables or a pattern, we call it pattern, that identify a cancer or a clinical significant cancer versus non-clinical significant cancer. And once we train the model, this model then will be able to extract the information from new cases and identifying those features that we were talking about, so pixel to radiopathological characteristics, to identify if that particular part of the MRI is related to a cancer or not. The real game changer will be, let's put it this way. When we see a patient, the real pathway in 2024 is the following. We have a patient with a suspicious prostate cancer. The patient undergo to a multiparametric MRI. The multiparametric MRI, let's say that is going to show a suspicious prostate lesion, which require a biopsy, which require a pathological evaluation. And afterwards, we will have a diagnosis. This kind of pathway usually takes, unless you're going to do one-stop MRI protocols, one of the things that we are, establishing here at the USC, will take between 15 to 20 days. And on top of this, again, you have to undergo a biopsy. AI can actually be able and will be able to predict the pathology from the radiology. And this is what we call the virtual biopsy concept. So where you have an MRI, the MRI can find you the suspicious prostate lesion, and the evaluation of the features within the lesion with multiomics, radiomics, genomics, and radiomics will provide you the actual evaluation, the pathological evaluation from the radiology. That is what we call the virtual biopsy concepts. But the real game changer will be when where the radiologist is not able to find any lesion. How many times you have a prostate, you have a PSA that is between 4 and 10, the MRI is not showing you any lesion, but then when you do a standard biopsy, here you are, you can find a tumor. So technically, and imagine the impact specifically on active surveillance protocols, not only for prostate, it can be, for example, for bladder cancer or for kidney cancer. If AI will be able to detect lesions or suspicious areas, region of interest, that could potentially be recognizable as cancer, clinically on clinical significant or clinical significant, where the radiology was not able to do that. Well, that is the real game changer in the active surveillance protocols that we are using right now.
So I know you don't have a crystal ball, but you just walked us through the process the way it is now. In 5 years, what is the MRI report going to say to us? Is it going to say, hey, this is a 90% chance that this person has prostate cancer? And will there be a threshold where, if it's a 30%, we don't biopsy, but if it's above that, we do? I mean, what do you think in 5 years is going to, using this specific scenario, how's it going to change it?
So the very first thing we have to consider is that we have to start changing our measurements. The PIRATS is a score, and we need to move from a score to an index. And this can be done with AI. Finding out a cutoff, for example, that is telling you, hey, there is a lesion, and the probability of the lesion of being a clinical significant cancer, let's say, is, 90%. In that case, you're going to do a target biopsy, increasing the necessary biopsy. The main thing is this one. Out of the, let's say, if you look at the numbers of the most current Cochrane review, that is looking at the standard biopsy alone versus standard plus target biopsy of the 9 randomized trial. As you can see here, the positive predictive value of the biopsy is 0.38, which means that we are actually right now doing a lot of unnecessary biopsy. So AI is the perfect sweet spot for increasing the positive predictive value, of reducing the necessary biopsy rate, and therefore increasing our performance as in diagnosis, and then of course in the active surveillance protocols.
How about AI imaging and renal cell cancer?
Oh, okay. So that is a very active, research right now. So imagine you have a patient of 85 years old, and he has a lesion of I would say 2.1 centimeter. And you don't know if this lesion can actually grow up or not. So technically, what we can do is, for example, doing an active surveillance, but you never know, right? Sometimes the patient undergo a partial nephrectomy, and then you find out there is an oncocytoma. So the patient could potentially have a complication. He's an 85 years old. I mean, we know that now 85 years old guys are like the old 50s. But again, is still a surgical procedure. So AI actually, and this is something that we have done here also at the USC, is the prediction, looking at the images of a dichotomization between benign lesion and malignant lesions. Our system showed with an internal validation that the system is able to discern between malignant and benign lesion with the 86% of accuracy, which is pretty good considering that it can be used for selected cases. And this accuracy is jumping up to 93% when also clinical variables are included in the model. So again, looking at this thing, AI can really be a perfect ally for us for reducing the workload, etc., but also improving our performance and becoming real avengers in urology.
How about, I know you do oncology. How is AI changing bladder cancer?
That is another excellent thing that we know that is on the making. So AI can be used, for example, for AI aid cystoscopies. We know that now blue light is showing excellent results in performance in helping us in detecting, for example, some lesions that were not even detectable before. But imagine if you can empower blue light cystoscopies or any kind of our cystoscopy like a narrow bind imaging also with AI. That, of course, requires a lot of training. Another option is the response to the neoadjuvant chemotherapy. We know that neoadjuvant chemotherapy can be the perfect way for reducing the stage of some bladder cancers, but again is associated with the complications. And when a patient has a complication, then you can delay at some point also the surgical treatment. So in this particular scenario, and sometimes is not even responding. So is having complication, is delaying the radical cystectomy, and maybe it's not responding either. So how cool would be if AI, looking at the images during the neoadjuvant chemotherapy treatment, can tell you before the radical cystectomy if the patient is a partial respondent, a non-respondent, or an actual respondent to the chemotherapy. That will change dramatically the way that we can select the patients. And once we identify the patient who are perfect respondents, well, that actually is going to be the real step forward that can be implemented together with AI imaging. But it's not only that. For example, it can be used for predicting the recurrence. At the USC, we have a very large database with almost 3,000 patients underwent radical cystectomy over the past 20 years. And we know that now there are some nomograms that can be used for predicting the recurrence at 2, 1, 2, and 5 years. But again, nomograms are excellent statistical methods, but again, are based on the fact that you are including in the model only the variables that were found to be associated with the outcome at the multivariable analysis. And that, of course, is based on the population that you used for training the model itself. Well, AI is different because AI is looking at the outcome, like recurrence, and is considering all the variables that you have available. And each variable will have a different weight. So you're not excluding anything, any one of them. And therefore, because each variable contributes a little bit to the outcome, then of course we can select the top 12, the top 6 to have the better performance. We can overfit in the model in a way that can be useful. For example, to be used, it doesn't make any sense having 80 variables right in a nomogram. You can select the top 12 or top 6. But again, this new kind of technology can actually give you a better prediction. Our studies are showing that compared with the same population, and comparing the actual nomograms for the recurrence of bladder cancer versus the system that we have developed here, we have a jump in 10% point in the prediction of recurrence at 1, 2, and 5 years.
Lots of applications in oncology. What about, let's take general urology. How does AI, or what's the potential for AI to impact, say, BPH treatments and therapy?
Well, that is another excellent question. So technically, we can find the perfect candidates. We have different, for example, we have different surgical options, right, for our patient with the BPH. And not all of them are suitable for all the treatments. And some of them probably would be benefit from aquablation, for example, compared to TURP. So the AI can be the perfect ally for identifying the patient and considering the best treatment. But again, human supervision is always mandatory. And this will make, again, AI an assistant and not AI replacing us. As I used to say, AI will not replace urologists, but urologists who will start using AI will replace who don't.
So these have been great examples. Talk about AI and social media promotion and patient information materials.
Oh, yeah. So we know that social media are used widely, not only for spreading medical information, but also to our peers, but also to spreading scientific contents also to lay people. And it has been reported that papers that are also promoted in social media got more attention, and therefore going to get more citations, but also are going to be used and criticized more than the paper that are not even shared on social media. But again, the sharing in social media require time, require expertise, and require also a wording to make sure that the concepts are going to be veiculated to different population, like lay people or our peers. So our team has just developed what we call the Chat GPT tweet. Is a new custom GPT that will be freely available very soon. That is able now to read through the abstract, extracting the important information, digesting the information in the social media lexicon, and creating a social media post in a little bit more than 10 seconds with an accuracy that is around 92%. We tested this with amongst 300 urologists over the world, and we find out that in terms of likability, shareability, completeness of the information, peers and urologists prefer the new version, but also we tested it with Amazon Turk workers. So lay people all over the world that read those new social media, they compare with the actual social media that were shared by the journals. And what we figured out is that even the general public prefer the new way for sharing this information. Again, small steps, small tasks, but again, the way is to reduce our workload and improving our performance.
Well, that's an area that you don't immediately link with artificial intelligence, is the ability to communicate with the people that don't have medical knowledge and things like that. That's really awesome. And I assume that at some point there'll be AI augmented reality videos of the operations, so the patients can watch them and that kind of thing. So
exactly, but not only that. I mean, I'm living in California. 30% of the population is not native English speaker, as me, and 70% of the 30% are generation zero, like me. That I came from Italy, I came here, and again, our native language is full of nuances, especially when we have to talk to a physician, right? And if I know that I have, for example, I'm Spanish and I have a Spanish speaker physician, I will be more inclined to go to him, or because I know that he understands. And also, there are some nuances when he's talking that I could potentially capture better. So technically, with the new system of generative AI, like for example, hygiene or synthesia, we can create new videos that enable any physician talking in Spanish, talking in Portuguese, talking in Italian, why not, and talking directly to your patients. Now Google, they have released these new glasses that in real time are projecting into the lens the translation while you're talking. That's the main thing. You don't need anymore an interpreter, because the interpreter will require that there is somebody else, and you are not. Sometimes you can lose some nuances. If you can read automatically in real time the script, well, that is a real game changer, especially for our patients that are not native English speakers.
Yeah, I know I've had my share of experiences where I'm using a translator, and I often wonder if the translator is actually getting what I'm actually saying, and therefore transmitting the proper information. So you've kind of talked a little bit about telemedicine before pandemic, after. How do you see? So we know that Medicare insurance companies are often way behind the evolution of the actual medicine and technologies. How do you see AI changing the billing, coding, and reimbursement structure?
Well, that is another excellent point. Again, AI can do the work of hundreds of people in the billing code. I mean, we know that identifying the correct billing, the correct codes, is sometimes very challenging, and sometimes you find that you lose, on the way, some codes that should potentially be billed. AI can actually go through, for example, the entire patient encounter, finding out your diagnostic, guessing, or your diagnostic performance, and then creating a list of CPT codes that can be applied to that. But it's not only this. I mean, again, imagine a rebuttal letters. How many times we are finding ourselves writing to the insurance companies that somebody else is saying, hey, you don't need an MRI. First, who are you to tell me that I'm not an MRI? At the end of the day, I'm a surgeon, right? I know what I'm talking about. Or, oh, you don't need a PET-CT because it's not required for this kind of patient. Well, every time you have to spend time in writing a rebuttal letter to the insurance companies. Well, technically now, we could potentially give them our time, because we have now an assistant that can, if you can provide evidences, can write for you a letter that you have to, that of course at the end you have to approve, but that will make everything easier.
Dr. Cacciamani, we have covered a lot of ground today. This has been absolutely fantastic. Are there any other things that you want to add?
Yeah, I just want to add this final comment. So again, as a urology community, before talking about deep learning, we really need a deep understanding. And therefore, as people that are working in academic centers that are working on AI, our main duty is deep teaching to the urologists what are the potentiality of AI. We have to take out from our mind the image of Terminator, or also those sci-fi movies where AI is taking over. Right now, AI can be the perfect ally for us in order for, again, increasing our performance, reducing our workload, and bringing back the joy to practicing medicine. And again, this is not a backup call. Is something that we have to consider that is real. And again, in my personal opinion, AI will not replace urologists, but those urologists who will start using AI will replace them.
Thank you, Dr. Cacciamani, for sharing your time and expertise with us today.
Thank you so much for having me here.
And thank you to our audience for joining us on the AUA Leadership and Business Podcast.
Are you or someone on your urology care team looking for practice management or coding and reimbursement education? If so, we invite you to check out AUA Coding Plus and the AUA Practice Management and Coding program on AUA University. Visit auau.auanet.org for more information and to register.